To introduce the next speaker is Professor Mahir Al-Hilali. Professor Al-Hilali is the medical director and a consultant hematologist at Mediclinic, Middle East. And he's going to talk about recent advances in laboratory medicine and opportunity for clinical and basic science research. Tfaddal.
Yes, we did last year, we did.
Good morning. Thank you very much for your kind invitation to this meeting. My role, I'm a hematologist by training and trade. I trained mostly in the UK for almost 25 years, then moved here to work for Mediclinic Middle East. Currently the lab director for Mediclinic Labs and also heading the new unit of precision medicine. If we look at what's happened over the last century, the leading factors were basically the telephone, electricity, and automobile. Now, in the current century and the future, a lot of disruption has happened, and the new technologies appeared. The most important are the genomic sequencing, artificial intelligence, robotic digitalization, energy storing, and blockchain technology. These are the drivers for the industry. These are the disruptor of healthcare. When we looked at laboratory service, and I run sort of 9 labs in the UAE, the problem with the laboratory service is that first of all, the specimen we take is basically the largest specimen. We take, sometimes we take up to 50 mils of blood from patients, and it's perishable. And the process of handling are very cumbersome. The test itself is sometimes non-specific and inappropriate, and there is poor correlation between the test and the pathology. There is low adoption of new technologies in terms of using of physics, ITs, and bioinformatics. Poor turnaround time for results. The lab tests are currently expensive. I mean, in some cases it costs 5,000–6,000 dirhams per test. There's poor automation with a shy use of artificial intelligence. Medical staffing shortages in histopathology in particular, and there is inadequate response to patient and clinician needs. So this is the current status of lab service as I can make it. So the new drivers for the new century has not really been adopted. There are a lot of disruptors for the technology and technology drivers for healthcare opportunities. Advances in IT, advances in technology and physics and molecular genetics has led us to see a lot of things that will change the provision of healthcare. So healthcare is changing. We have a lot of wearables now, advanced analytics, machine learning, communication, internet of has changed the way that we actually provide healthcare. So the lab service and lab testing, etc., has to change accordingly. I will emphasize, since this conference is basically is focusing on molecular genetics and its value, molecular genetics is not only for rare diseases. It will have a major impact on healthcare in general. And I will show you, I'll give you practical examples on how that's going to happen, how is it happening at the moment, and what's going to happen in the future. Molecular genetics basically deals with the human from the womb to the tomb. So from before birth till after death. And this has an impact on, there are different tests that we can do in the uterus for an NIPT, for example. We can test the embryo, whether for the embryo for health, and we can test after the delivery for any inherited diseases, heritable diseases. We can also test and predict different aspects of genetic constituents. We can basically maintain wellness through genetic testing. Genetic testing was a little bit more difficult. I've seen the old sequencer, the next generation sequencer. It was as big as a full room. Now you can fit it easily on a bench top. The principle of testing is basically, as you know, I mean, I'm not a molecular geneticist, I'm a hematologist, but basically the principle of that is that we can deploy molecular genetics and disease screening, such as screening for cancer, like colon cancer, diagnostics. We can also predict whether a disease can happen or not. And there's also application forensic work and also non-diagnostic ancestry. I think I'll go back to this slide. Basically, this slide is just show you the basic principle. It's basically the DNA is transferred to messenger RNA. The messenger RNA is through transcription produces protein, polypeptide, and anything that the body will produce to its functionality. There is a difference between the genotype and then the phenotype, as you know. The most important for us as a clinician is to recognize this difference. And we recognize that the genotype doesn't necessarily mean disease, while the phenotype is much more linked to disease process or health process. And there are a lot of factors. Genetic factors is one of them, and mutation, etc. Having said that, there are other factors which are epigenetic factors. These epigenetic factors will shape the genes and the gene expression in a way that could maintain or produce disease or health. A lot of environmental factors, nutrition plays a major role. Toxins. I was told that there are more than 190,000 different types of toxins, starting from plastic to others that can actually affect our health. And therefore, one has to be careful. Drugs, oh my God, it's a lot of drugs that we use, and a lot of us are on 5 or 6 different types of tablets. They are beneficial, but they do have side effects that can actually affect health adversely. And obviously pathogens. Pathogens, I will show you later that there are more than 27,000 species of pathogen, which is amazing. And the only way that we learn that there are so many is because now we can test their genetics and look for them by genetics. The healthcare revolutions happens from in the 800, where smallpox vaccine was discovered. Then a lady called Florence Nightingale worked in the First World War, and the only thing that she did is basically she introduced disinfection and advised the surgeon to wash their hand before surgery, not after surgery. And she reduced the rate of infection from 50% to 20%. Another one is the discovery of penicillin in 1945. A third one is the polio vaccine in the 1960s, by Salk vaccine. And then the latest one is the precision medicine. Precision medicine is basically choosing the right treatment to the right patient at the right time, and be very definite about it. I'm a hematologist, so I'll tell you about my experience. This is a condition, it's chronic myeloid leukemia. It's basically proliferation of white cell to produce leukemia. When I started as a trainee hematologist in the mid-80s, the condition was almost fatal. 3 years, the patient will transform from a chronic phase to acute phase. It's become acute lymphoblastic or acute myeloblastic leukemia, and the patient dies within months, if not days. The condition is caused by a translocation. It's 922 translocation. And as a result of this translocation, a new gene is formed called BCR-ABL gene. This is called Philadelphia chromosome, the translocation. But if you look at the gene level, you'll identify the BCR gene. And we do actually quantitative and qualitative analysis. The Philadelphia chromosome gene, this genetically, if we want to diagnose chronic myeloid leukemia, we can look at microscopy whereby we can see 1 in 100 cells. And in cytogenetics, you can detect it if the number of cells exceeds 100. Now, if you go more deeper into molecular, then you can detect 1 in 1,000 cells. And sometimes now genetic-wise, we can detect up to 1 in 100,000 cells. So log 5 reduction. This can be detected. And this is one way that we monitor the progress of patients with a chronic myeloid leukemia. if we go into the impact of this gene, what does this gene do? It's basically the BCR-ABL gene produce something like called BCR tyrosine kinase. The BCR tyrosine kinase is attached to substrate, and it promotes the production of white cells. What happened in the early 90s, this expression of this gene and the actual impact on the BCR on the substrate and proliferation of white cells was found to need energy, the ATP and ADP. In 1990s, or just before, they identify a molecule called ST571, which is basically imatinib or Glyvec. This molecule basically occupies the receptor on the tyrosine kinase, and through this, it will block the actual impact of the gene on the substrate, so prevent proliferation. This is the precision medicine. You got the gene, you got the gene product, you got the function of the gene, and you identify how to prevent the gene from working by blocking it. So this is one of the best examples of precision medicine. This is what we want to do in precision medicine. It's basically identify treatment which is very specific, and it will prevent that. Nowadays, chronic myeloid leukemia is a chronic disease, just like diabetes, just like anything else. We give medication, 1 capsule a day, and the patient survive. It has no impact on the life expectancy of the patient. So in the 90s, it was 3 years. Now it's the chronic disease. So this is a major example. The next high impact area, I'm moving away from rare disease to high impact area. The next high impact area is pharmacogenetics. Pharmacogenetics is basically identifying the genetic profile of the individual and identify whether the drug works or not, and this for this patient. We do respond differently to different medications. Some of us will use the standard dose, others will be very sensitive, others are resistant, others will not respond at all. You will be surprised to know, for example, that almost 50% of anti-diabetic medication are not beneficial to start with to the patient. They have side effects. But if you actually test them and find the most appropriate one, you can have immediately the good drug for diabetes, or good drug for hypertension, or good painkiller. And the reason for that is that we are different. Genetically, we are different, so the response is different. And this has an impact. At the moment we practice medicine, you go to the doctor, he gives you a tablet, the blood sugar remains high, say this is not working, we'll change it. So they do the same, and after 9 months they identify the top treatment. Now we can do it. We can look into what is there, what is useful, and then we apply it. The reason there is a pharmacogenetic differences is there is an enzyme called cytochrome P450, and there are almost 23 or 25 different types of it, and there are mutations in it, and that's why we behave differently as far as drug is concerned. And this is the different types and where it is and how we can actually identify the people who are sensitive or resistant to a particular drug. The reason why we change treatment is basically because the condition is not improving, there are unwanted side effects, patient takes multiple medications, or we are starting to take anticoagulant therapy. These are an indication for pharmacogenetic testing. Pharmacogenetic testing is going to come on, and everyone who is going to be on medication is going to need to have these tests. Yes, I think we can quickly say that the cardiologist, orthopedics, pain management, psychiatry, and internal medicine are going to be needed to actually look into pharmacogenetic much more closely. The impact of it, the financial impacts is huge in this sector. It's basically in the US, there are billions of dollars that can be saved as a result of testing in the field of mental health, pain management, and also thrombosis and clotting. Digital chemical pathology. This is a new area. We have a system called multi-top system. And the system is a benchtop system, and it's basically, it works by application of laser into any protein, a drop of blood or a drop of serum or urine, and this will lead an ionization, and you can measure the wavelength, and you will identify each component by a peak, or they call it time of flight of the molecule. As I said, this is used using a drop of blood as opposed to 50 mils or 20 mils. And you can define different chemicals and you can do a lot of testing that way. We can use the things for screening, for Down syndrome, early pregnancy, and breast embryo checking, and preeclampsia. And the way to do it is to obtain a drop of blood from the patient, and we actually tested using the MALDI-TOF technology. And you can identify the difference. For example, in Down syndrome, the protein, which is basically coded by the presence of this abnormal genes, is different from a normal pregnancy. And you don't need much. You need only a drop of blood to do so. The same applies. You can look for hemoglobinopathies, diabetes and prediabetes, and in oncology. And in the same principle, you can look at the peak of the protein or the product of the gene. This has been used in an experiment in India to identify the beta thalassemia and alpha thalassemia. As opposed to genetic testing, you can look to the impact of the MALDI-TOF technology into that. And if you deploy it, it's very cheap and inexpensive, and you need only a drop of blood. The next, on the last section, is the microbiome. Microbiology is going to change. It's now from simple culture and sensitivity into different technologies, RT-PCR, and then genetic sequencing, next generation sequencing. And now we look into metagenomics. The technology is different, it's becoming more sensitive and more responsive and also quicker. The turnaround time is quicker. As I mentioned to you, there are more than 27,000 species of bacteria, fungi, viruses that has been identified using this technology. The interesting bit is in the human, is the gut microbiome is very important. And if you look into the human and different regions, there are almost 1 trillion different type of bacteria that lives in the human, much more than the actual cells of the body. And the gut microbiome are considered the brain of the immune system because they release proteins and bacteria. The last thing I will say is that the microbiome technology and the microbiome research will have to be adopted, and a lot of research will need to be made. Interestingly, 70% only of the microbiome have not been previously identified and need to be researched into. I think my time is up, so I will have to go through. The most important thing is that a lot of database is being produced to link microbiome to diseases. This is the pattern of disease in the past. Now it's all autoimmune disease. Previously it was infection. Different population of microbiome is actually present in different conditions. Rheumatoid arthritis, asthma, osteoporosis, obesity and diabetes, and Crohn's disease and other inflammatory bowel diseases. The last point is that digital histopathology is there, and where artificial intelligence can be used to promote the services. The last thing is I will say the opportunities for research is basically try to take the next generation sequencing and genetic testing to be deployed in the areas of microbiome, pharmacogenetics, and other diseases, and a greater collaboration with universities are there. Thank you very much.
Thank you, Professor Mahir. Thank you. So we have a time for one quick question. Oh, two, but very quick one.
Okay, thank you, Dr. Mahir. Fantastic. So you heard me earlier talking about cellular mechanisms of disease, but basically the other major project that we are conducting at the moment, it's basically one of the largest in the region on implementation of pharmacogenomics in cardiovascular disease. So basically we are recruiting 1,500 patients with cardiovascular disease requiring clopidogrel, warfarin, and statins, and basically we finished analysis about 700 or 800, and basically the outcome is that about 40% of patients on clopidogrel are given either the wrong dose or the wrong medication, Statins, again, about 30 to 40% of patients are prescribed, either the wrong version of statins, basically. So my question to you, really, how widespread the implementation of pharmacogenomics in the UAE, and what are the barriers for implementing it?
Well, I think it has to start. The American experiment and the European experiment into use of pharmacogenetic has been very positive. Just take pain management. I know the cardiovascular are essential in the sense that if somebody goes to a cath lab to have stenting or whatever, if they are resistant to clopidogrel, then the chances of a blockage of the stent within 6 months is very high. And this costs, obviously, in addition to the patient life, it will cost a lot on the payers. It needs to be adopted by the insurance. At the moment, it is not covered. I think that if they look at the figures and the saving made as a result of molecular genetic testing, and the prices of molecular genetic testing is coming down now, if it's adopted by the insurance company, if the regulator or the government actually push for it, I think it is going to be beneficial to the patient and to the healthcare system. This is one area of development that I highly recommend. The adaptation now is very limited at the moment, unfortunately.
Thank you very much. I think my question is more generalized format rather than specific. I think you mentioned the precision medicine, a very good definition of precision medicine, and then you used the tyrosine kinase inhibitor as an example. Now, we do realize that sometimes precision medicine can be off-target. So if you can comment on, rather than, the on-target is fine because we know that it would cure or fix the problem, but sometimes we do have off-target effects of some precision medicine. If you can comment on this. The second part of the question, again, is generalized. Do you envision that one day we will have a full concoction of the microbiome that can be taken as a pill rather than the ones that are available right now that kind of maybe disrupt everything, that has this concoction of all of our bacteria needed and maybe age related? As you progress in age, then you can take one pill, a particular decade of your life. If you can comment on these things, I'd appreciate it. Thank you.
Thank you very much. Thank you very much for your kind questions. They are too dear to my heart. First of all, precision medicine. Precision medicine, you don't actually treat gene. You treat the impact of the gene. So if you want to be on target all the time, you have to look at the phenotype and how the gene expression has changed. So you look into toxins, environment, other things apart it, and then you will design a treatment which suits the patient so that you will be on target most, if not all the time. We are not going to prescribe that for this gene, you have to give this treatment. This is wrong. You have to look into the phenotype and the gene expression. You can have in the same family 4 ladies with the BRCA positive genes, but only one of them will have breast cancer. So the 3 of them will not. Why is that? It's because the gene expression has been modified by behavior, by toxins, by viruses, by others. So we have to be very specific. As for the microbiome is a field which is forgotten. There is a lot of problem that is caused by the gut microbiome and by the mouth microbiome and the vagina microbiome that is actually the cause of ill health. And now we know, I got a slide on the pattern of disease that I could not talk about because of the time allocation. The change of disease has changed. In the 50s, all infection. Now it's all autoimmune. Diabetes, obesity, autoimmune. And the reason for that is the vaccination, antibiotic therapy, treatment of infections, and others. This has affected actually ourselves. I'm available, obviously, after the meeting just to discuss for you all these because of the time constraint.
Thank you. I think we should leave it here. Thank you very much, Professor.
Pleasure. Thank you. Thank you very much.